want me to just start? Happy to jump right in.
Yeah, I could just introduce you first.
Okay.
Good evening, everyone. And on behalf of the CVP Interest Group and the SCVP, it gives me great pleasure to welcome everyone to our webinar on cardiovascular pathology. Our speaker today is Dr. Marc Halushka, Professor of Pathology at Johns Hopkins Medical School and the current president of the SCVP. He will be speaking on the evidence for COVID myocarditis. The talk will be followed by a live discussion by our expert panelists. We will also be accepting questions from the audience through our Facebook page, Cardiovascular Pathology. The talk will be posted on also to our YouTube channel later in the evening. Dr. Marc Halushka, I would like to invite you to begin your talk.
Thank you very much, and thank you so much for having me. It's an absolute honor to be here, and I understand things are really picking up with COVID again in India, and I'm so sorry to hear that. We are in the midst of our fourth wave now in my state in the United States. And so therefore, this seems to be a very topical discussion point for us this evening, which is to discuss what is the evidence for COVID-19 myocarditis. And so what I'd like for everyone to take home from this conversation is to kind of understand the short history of SARS-CoV-2 myocarditis. I'm going to also describe features related to a myocarditis diagnosis, how we get to that point, and then discuss the data in favor or in opposition to COVID-19 myocarditis. Now, let me begin by saying that I'm sure we all know that the coronavirus SARS-CoV-2 is the cause of COVID-19. COVID-19 got its name because it was discovered in 2019, late 2019. But the early information we started to receive wasn't until March of 2020, and this information came out of Wuhan, China. And the information that we got was very concerning that there was a big cardiovascular component to this disease. And so one of the papers published in mid-March talked about a coronavirus fulminant myocarditis in a patient who ultimately survived. Another paper from early March talked about SARS-CoV-2 as a potential novel etiology of fulminant myocarditis. And then another paper in late March talked about cardiac involvement in a patient with coronavirus disease 2019, saying these findings were consistent with an acute myopericarditis. So as pathologists reading these papers, I and others became very concerned we were going to see a lot of myocarditis and very severe myocarditis in these individuals. And right around this time, there was a large email group that came up of a bunch of autopsy pathologists and cardiovascular pathologists who were very interested in helping out to try and generate knowledge about this new SARS-CoV-2 virus and what this was doing to the body, as we knew that unfortunately many individuals were passing away from COVID-19. And so you can see there was a lot of interest, but there were a lot of places that struggled to be allowed to even do autopsies in these individuals. And so probably one of you on this call is this top quote: "We have not been allowed to perform an autopsy in these cases." This again was early in 2020. From New Jersey, United States, as soon as my institution lightens up on restrictions to autopsy, we will be happy to contribute. Not allowed to do any postmortem sample in my hospital from Paris, France. And then fortunately, a few places were able to start to contribute. I would be delighted to help with this vital work from London, England. We're very happy to lend a hand here at Mayo from the Mayo Clinic in Rochester, Minnesota. And so there was definitely a call and a need to do autopsies to understand this disease. And there was a push to find a way to move forward. So in April of 2020, Max Buya, who's a colleague of mine and the editor of the Cardiovascular Pathology Journal, had a call to action talking about the need for autopsies to determine what's going on in COVID-19. And then we just started to see a few cases trickle in. So on the right, we see autopsy in suspected COVID-19 cases, which provided guidelines and a safety protocol for autopsies. And I always enjoyed seeing this paper because this first image was nothing more than a pathology technician just dressed to do an appropriate autopsy of COVID-19. And remember, back then we had no idea how dangerous COVID-19 would be, how much if someone was to perform an autopsy. It may release virus into the air and infect the entire hospital, and what we needed to do to be careful. So there was a lot of concern because there was a lot of unknown at the time. One of the first reports that I saw of autopsies performed in the United States was this 2 cases performed in Oklahoma, no evidence of myocarditis. And then more autopsy case reports started to trickle in small case series as well. There was an early publication of 3 cases showing endothelial injury. There was a small series from Sharon Fox and Rick Vanderhyde in New Orleans of 10 cases. They did not show myocarditis, but they did show individual cell necrosis. And then this 3rd publication in July of 21 autopsies also didn't show myocarditis, but did show myocardial cell necrosis. So this is sort of where we were with autopsies. Little reports, a couple of cases at a time, a small series, and not much discovery. Now, by this time, I also had started to see the heart slides of some of the autopsies we had performed at my institution at Johns Hopkins. And although I was expecting to find all this exciting pathology, the reality was most of these cases showed almost nothing but some chronic cardiovascular diseases. So I think we started to become more comfortable with the idea that myocarditis, as much as we were anticipating it being a big component of the disease, wasn't going to be a big component. Unfortunately, our clinical colleagues really got ahead of us in pathology. And this paper came out in JAMA Cardiology, and I just refer to it as the Puntman paper. I'm going to describe it here. And that really changed the concept of COVID myocarditis. And what they had done in this paper was look at 100 individuals who had recovered from COVID-19 and to see what long-term sequelae they had in the heart. And of these 100 individuals, 78 had abnormal cardiac MRI findings. 71 of them also had detectable high-sensitivity troponin T. And as you know, high-sensitivity troponin T is a marker of myocardial injury. They also done an endomyocardial biopsy or 2, which revealed active lymphocytic inflammation in an individual. And this is a direct quote from the paper. There was ongoing myocardial inflammation in 60 patients, or 60% of these individuals. And this was interpreted to mean that 60% of people who had COVID had developed myocarditis. Well, this was a huge story. This was a big concept that more than half of people who had COVID were going to have myocarditis. Again, that didn't square with the initial autopsy data we had, but we didn't have that much autopsy data. And this paper set off a lot of panic buttons, at least in the United States. At the same time, there was concern that not only could myocarditis occur in older individuals, which is what the Puntman paper evaluated, but that myocarditis could occur in young, healthy people. And this was a publication looking at 26 athletes, of which 15% had cardiac MRI findings suggestive of myocarditis, and 8 athletes had findings suggestive of prior myocardial injury. So this was also a really big concern. One of the things we have in the United States is a lot of athletics among children, teenagers, college students. And there was a concern that if these individuals developed COVID, became positive for COVID, and then continued to play sports, they would develop myocarditis and potentially die. And the general press, the newspapers in the United States, picked this up and wrote very scary stories about COVID myocarditis. And I think one of the first one of these papers that made a big mark was in the Washington Post, which is one of our major newspapers. And it said, health experts worry coronavirus could cause lasting heart complications for athletes. Just after that, ESPN, which is a major TV station with multiple sports network channels, as well as a big online web presence, talked about heart conditions linked with COVID-19. And this one says, fueled Power 5 concern about season's viability. And what this meant was that there are American football is played in college. It's very popular. The Power 5 are the largest universities that we have in the United States that play football. And they were all thinking of shutting down their seasons because of concern of transmission of COVID and potentially injury to the students who were going to play, that it would have been very irresponsible to let these students play if such a high percentage of them were going to develop myocarditis. Now, ultimately, most of the programs decided to play college sports, but a lot of that was postponed. Some of it was canceled completely, but many of them were just delayed by a month as they worked through the concept of COVID-19 myocarditis. Now I'm going to stop talking about COVID-19 myocarditis and talk about myocarditis for a moment. How do we define myocarditis? And the only real definition that we have that we use are the Dallas criteria. And the Dallas criteria are really designed for biopsy classification. And so for those of you who don't know much about where we got the Dallas criteria from, let me go back and tell a little story. Many years ago, I think it was roughly 30 years ago, there was going to be a big clinical trial to look at steroids for myocarditis. So if a person developed myocarditis, would it be useful to put the patient on a regimen of steroids? And the problem was that you had different cardiovascular pathologists at different institutions that each had different sets of criteria to diagnose myocarditis. So there was no consistency from institution to institution, and this was a multi-institution trial. And so the way that they were able to solve this problem was to bring a bunch of cardiovascular pathologists together in Dallas, Texas, put them in a room, give them a bunch of microscopes and a bunch of slides, and say, figure out a consistent criteria that everyone's going to use to evaluate myocarditis. And so this is what came out of it. But there are basically these three different levels. The first is the diagnosis of myocarditis, which is myocardial necrosis, degeneration, or both, in the absence of significant coronary artery disease with adjacent inflammatory infiltrate with or without fibrosis. So that's saying you need myocardial damage and adjacent inflammatory infiltrate, and that's primarily a lymphocytic infiltrate. There is also a sort of an intermediate, which they called borderline myocarditis, and this was an inflammatory infiltrate too sparse or myocyte damage not apparent. And the challenge here is that when you have an endomyocardial biopsy, it's a very small piece of tissue. It's a very small piece of the heart, which is like a window on the heart, but doesn't give you all the information. And you could just be missing a larger process by having that little bit. Myocarditis, as you know, is very patchy. It's hit or miss. It's heterogeneous in its distribution. And so if you see a little bit of inflammation, it could represent the tip of the iceberg, that there's a larger myocarditis in the heart, or it could be just a little bit of inflammation that doesn't really mean very much. As you get older, some of us will just get small collections of lymphocytes in our heart, and we shouldn't overthink it. And so this second category gives pathologists the ability to suggest there might be something there, and in the right clinical setting, it may be we simply missed it on our small amount of tissue. And then the third criteria is no myocarditis. So that'd be no evidence of myocardial necrosis, no evidence of an inflammatory infiltrate. As I said, this is only designed for biopsy classification. There is no accepted definition for autopsy, although I've seen people use the Dallas criteria in autopsy studies. It's probably inappropriate, but again, there's nothing better that we have to offer. But perhaps the closest thing we have at the level of the autopsy comes from this nice guideline for autopsy investigation of sudden cardiac death that was put out by the Association for European Cardiovascular Pathology. And in this paper, they had a number of different categories for how to evaluate sudden cardiac death. And in their certain category, they said massive acute myocarditis is a cause of sudden cardiac death. So if you were to do an autopsy on an individual who died suddenly for unknown reasons, and you see a massive amount of acute inflammation, that is a reasonable cause of death for this sudden cardiac death. What fell in the uncertain category is if you just saw some focal myocarditis, a little bit of inflammation and injury, not clear that would be enough to cause sudden cardiac death. They also had a table where they talked about the gray zone between physiological and pathological changes in myocardial disease. And this is just part of a larger table, but in the setting of inflammation, you can see it both physiologically and pathologically. So under physiologic change is scattered inflammatory foci with or without small foci of fibrosis. And under the pathological side is borderline or focal myocarditis. I want to read the comment to you. I think it's very useful. In the absence of myocyte necrosis, small foci of inflammatory cells, even after immunohistochemistry, are not sufficient evidence of myocarditis. Scattered small foci of fibrosis are also insignificant. Both findings should prompt examination of additional blocks. Viral infection should be excluded by molecular techniques. So again, what they're saying here is that it's okay to see some inflammation in the heart if you have a lot of it to evaluate, that a few small foci of inflammatory cells does not get you to the diagnosis of myocarditis, and it would not be a cause of death. And actually, this echoes exactly what Margaret Billingham had said back in 1987. So Margaret Billingham, for those of you who don't know, is one of the great cardiovascular pathologists of our time who had done a lot of work with diagnosis and criteria for making certain diagnoses, particularly endomyocardial biopsies for transplant. But she said in this paper, focal myocyte necrosis and inflammatory infiltrates do not result in heart failure. In fact, it is clear that only fulminant diffuse infiltrates that are present in every biopsy fragment lead to heart failure. This experience makes a strong case against labeling focal infiltrates as myocarditis. If the patient is already in heart failure, another cause should be looked for. Small focal collections of acute or chronic inflammatory cells and isolated microscopic fields must not be overemphasized if clinical credibility is to be retained. And I think that's really true. So in my experience as a cardiovascular pathologist, I see lots of explanted hearts for patients who've undergone transplant in my institution. And many of them have small collections of inflammatory cells, but that is not the etiology of their heart disease that led to heart failure. Some of them have a known dilated cardiomyopathy or a hypertrophic cardiomyopathy unrelated to these small collections of inflammatory cells. And once you start to appreciate that you can randomly come across these small collections of inflammatory cells, you learn to not overthink that as a diagnosis, and to not label every collection as myocarditis. So another question, going back a little bit now to SARS-CoV-2, is do coronaviruses in general cause myocarditis? And what's the history of coronaviruses as a cause of myocarditis? And as you all know, coronaviruses are very popular, very common in our communities. Most children have had multiple coronavirus infections, usually just of their nose, causing the common cold throughout their lives. I would argue that we've had billions upon billions of coronavirus infections of humans over many, many years. And yet this was a list back in 1991 of all of the causes of myocardial inflammation. And you can see that there are a huge number of viral causes of myocarditis listed, starting with Coxsackie virus, echovirus, adenovirus, influenza, and so on. But coronaviruses are not on that list. Additionally, we know of two more severe coronaviruses that have appeared. One was SARS-CoV-1, which had sort of a limited infection group in Canada and some other parts of the world where there are about 8,000 cases. And fortunately, this one we were able to get our control over before it became the huge pandemic that SARS-CoV-2 has become. But there were no reports of myocarditis among those 8,000 individuals. We also have MERS, Middle Eastern Respiratory Syndrome, also caused by a more severe coronavirus. And in MERS, there's been one case report from about 2,000 cases of MERS. And that case report was a clinical case report without any histology confirming myocarditis. So historically speaking, coronaviruses were not known to cause myocarditis. Now, what does it take to actually get to a diagnosis of myocarditis? If you saw histology like this, I think we'd all be very comfortable saying that this is myocarditis. Here on the left, at a higher power view, we see a brisk inflammatory infiltrate with lots of inflammatory cells. And at the top of this, and I don't know if this will project, but there is some injured myocytes. So there's some broken up cardiomyocytes with many inflammatory cells surrounding them. The same is true in the middle. And on the right side, The lower power view shows, again, a brisk collection of inflammatory cells, predominantly lymphocytes. This one has a fair amount of fibrosis, indicating this has been going on for some period of time. So I think we'd all be comfortable with something like this to make a diagnosis of myocarditis, whether it was on endomyocardial biopsy, which is where I took this picture from, or if it was on a large heart where we saw a lot of this material. Now, this is a little different. If it was an endomyocardial biopsy, both of these images would be sufficient to call it borderline myocarditis, and I would actually use that term, myocarditis. But if I were to look at an explanted heart or an autopsy heart, and this is all of the inflammation that I saw in the case, it would be very hard for me to get to a diagnosis of myocarditis. I would describe this as a collection of lymphocytes in the heart, and I would avoid using itis or myocarditis. I wouldn't want clinicians or anyone else to think that I was saying that this was a true myocarditis, particularly as related to a cause of death or a need for heart transplantation. Again, small collections of lymphocytes can occur. And in a biopsy setting, we would call that borderline myocarditis, where you have lots of tissue that you can evaluate, and maybe something like this would make me want to add additional sections of the heart and go back and evaluate more. And not seeing much more than this, I would only call this collections of lymphocytes rather than myocarditis. So that takes us back to COVID-19 myocarditis. How common is COVID-19 myocarditis? Again, those early reports were a fulminant myocarditis. There was some concern that this was a problem. We didn't see much of it by autopsy initially, but maybe there was more than meets the eye. And one of the challenges, though, was after the Puntman paper suggesting that 60% of people had myocarditis, we didn't have a big number of autopsies in any of these studies to have a big denominator. So if you have a small denominator, if you say, I've only done autopsies on 10 people, if you have one case of myocarditis, it looks like myocarditis is 10% of people. But if you had one more, it suddenly doubles to 20%. That's a big increase. But how accurate is this when you're dealing with very small numbers? We don't really know. And so there's clearly a need to have enough cases in a single study to say something meaningful about the rate of myocarditis incidence at autopsy. And what happened was I was talking to my colleague Joe Malashevsky, he's at the Mayo Clinic, another cardiovascular pathologist, and we were sort of lamenting about the Puntman paper, suggesting that it was misleading our colleagues because we didn't think that myocarditis was that frequent. We had other concerns with that paper, as many people had. And we ended up writing a commentary in circulation. As we were working on the commentary, I thought I would try and throw together what I could find as far as cases of myocarditis in autopsy studies. And so just sort of in an hour, I found 12 different studies, which had 165 individuals in them and 6 cases of myocarditis. And that led me to think I should really do this in a more rigorous fashion and go through the complete COVID-19 autopsy literature to understand how common myocarditis is in this entity. And so really the question was, what could the summation of autopsy studies tell us? And so what I did was I went through the literature and I found every autopsy study that was available to me at the time. And from those studies, there were 277 COVID-19 positive autopsies from these 22 different studies. And I said they all had to be SARS-CoV-2 viral PCR positive. There was only one exception to that. One of the studies said that 9 of the 10 people had a positive PCR test and 1 did not, and they didn't distinguish who that 1 wasn't. So I didn't want to lose the other 9 people. Thus, 1 person didn't have a positive known test, but had symptoms of SARS-CoV-2. And all reports had to be series. I excluded all case reports because those are more biased into some interesting finding. And I was interested in just the generic concept of COVID-19 autopsies. The information that I collected was heart and vascular autopsy findings, heart weight, comorbidities, autopsy type, and clinical time course. Now you can see that COVID-19 autopsies were conducted widely across many different countries. And in fact, 9 different countries contributed, although the United States and Germany were the places where I had the most information coming in from. There's also a wide range of autopsy practices. Some places were doing complete autopsies. Some were very limited to just a couple of organs. Some were doing biopsy autopsies where they just biopsy tissue without opening the body completely. Some people were avoiding to take the brain, again, out of concern of COVID-19. So a wide range of processes went into this. And these are the subject demographics from the group. There were, again, 277 autopsy hearts across all of these 22 different reports. 165 of these were consecutive autopsies. That's useful because, again, that reduces the bias in what autopsies were selected. You can see that 62% of the individuals were male. The average age or the median of age was 75, so an older group, but that's what you would expect because, as we know, COVID-19 is a big killer of the elderly, and fortunately the younger people do better with the disease. The body mass index was 26.9. It was significantly higher among the American autopsy subjects. There's a lot more obesity in the United States than in Europe and other places. Disease length was about 10 days. There was a fair amount of heart disease. About half of these people had heart disease or hypertension. A third had diabetes. And then a number of other diseases are also seen there. And again, as we know, comorbidities are associated with an increased risk of death from COVID-19. As we get into the heart findings, you can see that the median heart weight was 483 grams, although we only had data on 73 of these individuals. Cardiac amyloidosis was present in about 4% of cases. Myocarditis was reported in 20 individuals of the 277, suggesting a rate of 7.2%. There was also reports of pericarditis, non-myocarditis inflammation, single cell ischemia, small vessel thrombi in about 11% of cases, macrothrombi in about 19% of cases. And macrothrombi didn't just have to be in the heart. We were including pulmonary emboli, deep vein thromboses, splenic artery occlusions, any vascular event that occurred. And then you can see at the bottom, acute myocardial infarction occurred in 4.7% of these individuals. Now, one of the things that I noted as we were going through the data and pulling it together, there was a strong diagnostic bias by study, meaning that the distribution of all these cardiovascular findings was not normal. It wasn't the normal distribution across cases. It seemed to be that certain institutions or studies were reporting very high incidences of some entities relative to everybody else. And so on the left side, you can see 21 different studies. Now, I mentioned there were 22 studies, but 2 of the studies out of Germany had the same population in them. So I just combined them all into the larger study, which is study number 4. But here you can see that megakaryocytes were described in all of the cases in study 6 and all of the cases of study 20 and not anywhere else. And so why is that? So it could be that only those 2 pathologists were looking for megakaryocytes and other people may have not noticed them. It's a more subtle finding. It could be that they had their own biases and over-calling things as megakaryocytes that no one else would call a megakaryocyte collecting in the vasculature. But you can see that it's not a normal distribution. We would have expected those dark bars, which represent positive cases, to be a little more distributed across the various studies. And the same thing was true in myocarditis. You can see on the right side that many cases didn't have myocarditis at all, which was fine. But one case in particular, one study in particular, had 12 cases of myocarditis out of 22 total autopsies. So over half of their autopsies had myocarditis, which is very different than any other autopsy series in the group. So we decided to do a deep dive on these diagnoses of myocarditis. And we went and very carefully read what they said, looked at their images. And I want to provide some of this information for you. Now, as I said, they had found myocarditis in 12 of 22 cases. And the direct quote from their manuscript was, active myocarditis characterized by mononuclear, predominantly lymphocytic infiltrate, and was associated with focal myocyte necrosis, fibrinous and hemorrhagic areas with myofibrous disarray. And these are the two images that they provided of the heart. And I put the arrows on, the yellow arrows, and I presume the image on the left has this small collection of a few lymphocytes around some fibrous tissue near a blood vessel. Excuse me. And it looks like on the right that there's potentially maybe an injured myocyte there, a single cell dropout with maybe a few extra lymphocytes around it. And that's it. So out of 12 cases, these were the two best images they could provide to demonstrate myocarditis in all of their cases. So I find this very unlikely to be real myocarditis. In fact, I emailed these pathologists who put out this paper and asked them, could they provide me with more information? And they declined. So I don't know if that's real myocarditis in these 12 of 22 cases. And I honestly don't think that it is. A second study that showed myocarditis was the well-known study from, again, the AECVP and the Society for Cardiovascular Pathology, who got together and published a manuscript in the European Heart Journal. And here they described myocarditis in 3 of 21 cases. And they had very strict criteria for calling myocarditis, which was written in the manuscript as myocarditis is defined as the presence of an inflammatory infiltrate associated with myocyte injury, not due to some other cause, which was present in multiple foci. And here's the images that they provided of the cases of myocarditis. And clearly across the top, that's the first of the 3 cases, you can see at low power, lots of injury on the far left corner, and then as well in B, and there's increased darkness is a bunch of lymphocytes, and very clearly there's a myocarditis going on here. The same is true on the second row with a lot of inflammatory infiltrate you see on the far left side, and then zoomed into higher power on the right. And on the bottom one, there's clearly an area with inflammation, more inflammatory cells, and some injury. I'm going to give this group benefit of the doubt. These are all cardiovascular pathologists. So at least 2 of them are brisk myocarditis, and the third one is likely to be another myocarditis. So yes, we are seeing some myocarditis in cases, but it's probably not every report of a myocarditis turns out to be myocarditis. And I remind you that going back to March of 2020, we as pathologists were primed to be looking for myocarditis. That's what we thought coming out of Wuhan, China, we were going to see a lot of myocarditis. And so everyone was looking hard, perhaps too hard, to make the diagnosis of myocarditis, even when what we were seeing might just be physiologic changes in a heart. Again, people who died of COVID were going to have comorbidities and sicker hearts in general, and they're likely to have more inflammation. So let me give you some final thoughts then on this myocarditis study. Again, this is work that I had done, I should say, in collaboration with Rick Vanderhyde as well. So of the 277 cases, in no situations was myocarditis listed as the cause of death. So we had a lot of cause of death statements. Occasionally it was acute myocardial infarction. Sometimes it was from thromboses like pulmonary emboli. Sometimes it was pulmonary failure just because of the lung damage. Sometimes it was stroke or something else, but in no cases was it ever called myocarditis. Of the 20 reported myocarditis cases, 16 I would consider, and Rick agreed, were questionable and are more likely non-specific inflammatory infiltrates. Again, I think it's people who weren't well versed in myocarditis, who wanted to make things myocarditis because that's what we expected to see in COVID, who were simply overcalling some random distributions of inflammatory cells. Therefore, probably 4 of the 277 cases, about 1.4%, was a probable rate of myocarditis, true myocarditis. And that makes myocarditis in COVID rare. And this is COVID that was so severe that it actually caused death. Like, this is not just anybody who has COVID, this is the real severe cases. Only a small fraction of them develop myocarditis. But even though this is rare, there's been over 130 million cases of COVID reported around the world already, and this is a vast underreporting. It's probably closer to 500 million people who've been infected with COVID. So even at a percentage of 1.4%, that's still a lot of myocarditis occurring. So it is real, it is just rare relative to everything else going on in COVID. Now, that was just our study of 277 individuals. Fortunately, there's been other papers that have said something very similar. So this was a large multi-institutional study of 135 autopsies from 19 centers that was led by Jody Hooper, who is an autopsy pathologist at Johns Hopkins. It was basically a survey of all of her colleagues in the autopsy world of cases they had and just what information they could provide about them. Myocarditis was described in 8 of these subjects. That's a 6% rate. What I don't know is how many of these cases were true myocarditis or potentially overcalled again. These were not all cardiovascular pathologists contributing this information. These were general autopsy pathologists, and they may have the same biases that I reported back in our earlier manuscript. But let's say these 8 were real. Another paper came out very recently of 100 consecutive autopsies performed at Mount Sinai Hospital in New York City. They had no reported cases of myocarditis in this entire group, but did describe mild interstitial chronic inflammation in 4 of 97 hearts. So I guess 3 autopsies didn't have any heart material evaluated. They also saw myocyte hypertrophy and interstitial fibrosis in 96 of the 97 hearts, suggesting everyone had some chronic cardiovascular disease. So if you put these 3 studies together, this is 100 autopsies, 277 autopsies, and 135 autopsies, you're at about 500 autopsies, and we have about 12 cases that may be real, suggesting a rate of 2.4% or so myocarditis across 500 individuals. So again, across these large studies, myocarditis fortunately seems to be a rare entity. But that's not to say if people aren't having cardiovascular disease and cardiovascular problems. It's very clear the high sensitivity troponins are elevated in lots of people with COVID. The cardiac MRIs are showing damage or changes. Now, I should say something about the cardiac MRIs. The people in that space, the imagers, use something called Lake Louise criteria to make the diagnosis of myocarditis. The challenge is that the Lake Louise criteria were designed for certain clinical scenarios under which you would get a CMR, which are not the same clinical scenarios that you would get an imaging done in COVID-19. Therefore, when they see some changes by CMR in COVID patients, they are jumping to myocarditis, which is probably not true. There's changes to the hearts, but it's not going to be myocarditis. So there is heart damage occurring, but it is not typical myocarditis, like a lymphocytic myocarditis. So if it's not that, what is going on? Well, there's been a couple of papers recently that really lend a lot of support for microvascular disease in the heart. And this makes a lot of sense. So we know that COVID is a bit of a vascular disease. There's been a lot of evidence that there's damage to endothelial cells, not by direct infection of the endothelial cells, but by the inflammatory milieu created by the COVID infection. That's resulted in macrothrombi and also microthrombi. And so work out of the Mayo Clinic by Melanie Boyce and Joe Malashevsky showed non-occlusive fibrin microthrombi in 12 of 15 of their autopsy cases for COVID-19. And a second paper that has come out, this is work by an Italian group in conjunction with Renu Vermani and Stevie Path, showed microthrombi in 9 of 14 hearts with myocyte necrosis. So there were 40 hearts in the study, 14 of which showed myocyte necrosis, and of those, 9 also had microthrombi. And here we see on the right, this is pictures from Melanie and Joe's paper, that there's these small thrombi that were collecting in hearts. So this is also something that I observed in some of the autopsies I saw at Johns Hopkins, and not with the exact same frequency, but we certainly noted them as well. And that, again, is consistent with what's going on. Now, this is very useful information, I think, and cardiologists should take note of this because, unfortunately, they had jumped to the conclusion that this was myocarditis. And the treatments for myocarditis are very different than the treatments for thrombi. And as a result of that, I unfortunately think that many patients haven't been treated effectively when high sensitivity troponins have become elevated, the clinicians have jumped to the wrong conclusion and aren't focused on treating microvascular thrombi or other causes relative to myocarditis. So I just want to leave you with a couple of final thoughts. From the onset of the COVID-19 pandemic, the concept of common SARS-CoV-2 myocarditis has been driven by clinicians. The Puntman paper is really the big paper that made clinicians think that myocarditis was very common. We don't think this is true. I don't think this is true. I've reached out to the people who run a long COVID clinic at my institution, asking how much cardiovascular disease and how much myocarditis they've seen in patients, and the answer was they haven't seen any yet. That was a few months back. So we don't think that's true. But we do think that the work of scores of pathologists, autopsy pathologists, and cardiovascular pathologists have shown that COVID myocarditis is rare. And I think that's the major contribution that we've been able to provide to the larger community. And I saw this tweet, which I absolutely loved, that said, as cardiologists and radiologists fought with journalists about frequency of COVID myocarditis, it took pathologists to settle the matter. Pathologists are the Vito Corleone of medicine. So for those of you who don't get that reference, Vito Corleone was the godfather in a series of very popular movies in the United States, the Godfather movies. And what he said was it. He was the mob boss, and whatever he said went. And the point is, we as pathologists have shown that it is not myocarditis that's causing the heart disease, it's some other causes that are occurring. And so with that, I want to thank you for your attention and time and open this up for questions and discussion.
Thank you for a wonderful lecture, Dr. Halushka. I think you've given us a lot to talk about and think about. We don't have any questions on the Facebook page as yet, so I'd like to invite the panelists to get going.
Great. So let me start out with a question for you. As you saw early on, autopsies were not being performed in India for COVID-19. Has that situation changed?
Not really, no.
Okay.
In fact, what they're doing is like a restricted autopsy, more like biopsies, but the main focus of interest is the lung and not the heart. Now, looking at all this COVID situation, I feel that this is one kind of an infection where there has been a, what shall I say, a justifiable over investigation. And they have shown that this COVID practically affects, all the organs. Now, when you talk about, viruses, a virus is going to go everywhere. So why they are saying that now, oh, this COVID virus is present in the feces, it is present in the gastrointestinal secretions, everywhere. So I really feel that a virus is doing a job of going everywhere and possibly it will attack some organ which it likes. That is one observation. The second thing is that somehow when we talk about, say, cases of, say, hepatitis E, or in cases of septicemia, how often we are actually doing any kind of imaging studies for the heart. It is quite possible that even in those cases, there might be some involvement of the heart, which may not matter much. So I'm sure the same type of analogy can be applied to even COVID, that you might get inflammation, you might get microthrombi, but as you're saying, the cause of death is not necessarily related to cardiac failure. And the other thing which I found in many of the series, which are calling some things as myocarditis and calling some things as, microthrombi, is it like a part of a disseminated intravascular coagulation, or are the microthrombi getting deposited only in the heart and the lungs, or is also there a concomitant sort of renal involvement? No one talks about the microthrombi which are present in the glomeruli. But the ultimate pathogenesis which they give in their discussion is everything like a DIC? So why no one is talking about thrombi in the glomeruli of the kidneys? I don't know whether you have reviewed that in your autopsy review about how much was the thrombi in the kidneys.
Yeah, so you bring up a lot of really good points and questions, and I'm going to get to that one third of the things you brought up. The first question or the first comment you made about virus being disseminated widely is true. Now, the virus is clearly in the bloodstream and it is disseminated everywhere in people with severe disease, can end up in the stool, as you mentioned. Uh, the big question is what cells will it actually invade? It needs a way to get into a cell. So it could be everywhere, but it has to get into a cell. And as people describe it, usually uses the ACE2 receptor and TPRMS2, if I'm saying that correctly. And I remember asking this question a few months ago or a month ago, just in the general audience, of what is this cell type in the heart that is infected by this virus? What do people think based on all of the literature that has come out in the past year? And the answer that I got was completely different by different people. So some people thought it was the myocyte. Some people thought it was the endothelial
Endothelium.
cell. Some people think it's an interstitial cell. And so there's a lot of evidence out there that points in different directions. Going back to the heart, there have been several studies in stem cells, iPSC cells, which are very primitive cardiomyocytes, showing that in a dish, you could get them infected with the virus. There have been at least 3 papers that have shown that. That is true, but that cell type is a bit different than a mature adult cardiac myocyte, and I'm not as convinced that that's a very typical event. There's a question in the chat about EM studies, and my colleague Renee Rodriguez at the Cleveland Clinic showed what I thought was a very convincing example of a viral particle in a cardiomyocyte in a patient with severe COVID infection. But I think that's the exception to the rule and not necessarily the rule. So again, the virus will go everywhere. What it's invading in the heart is still kind of an open question. There have been many studies that have pointed in different directions, and I don't have the right answer to that. The last part was about the kidney and disseminated disease. So yes, I do believe that you are having microvascular thrombi throughout the body. It's not just the heart. I think this is why some people have neurologic complications as well. They're probably having microvascular thrombi in the brain that are probably knocking off some neurons as well. Then you have to have some neuroplasticity to kind of fix that afterwards. I think we're seeing that in the spleen and elsewhere. I think it's going on in the kidney, but I'm not an expert in the kidney, and so I don't know enough about the literature there, but they've certainly been evaluated in COVID-19.
Yeah. Thank you.
Certainly.
Through the Facebook page, Andrea sends her congratulations and greetings from Argentina. Martin says hello from Hungary, and he would like to know if you have any experience with pediatric cases.
Oh, that's a great question. So yes, one of the challenges of COVID, or one of the real sequelae, has been this MIS-C, this multi-inflammatory systemic disease in children. And I have seen one autopsy at Johns Hopkins in a child who died of this, which was awful. And then I've seen other cases from elsewhere, 2 other people. And they all had the same histologic appearance in the heart. They do have this myocarditis appearance. They had a robust inflammatory cell infiltrate in the heart, but it was different than a typical viral myocarditis. So when I think of a garden variety Coxsackie B infection, I think of collections of lymphocytes around cardiac myocytes, damaging them in clusters. This was a diffuse process with lots of inflammatory cells and a perivascular distribution, almost as if they were attacking the vessels and not so much the cardiac myocytes. And all of the examples I saw, the amount of myocyte damage, while present, was low relative to the amount of inflammatory cells. And I also noted in the case we had at Johns Hopkins, a fair amount of edema or swelling in the perivascular region. So I really think in that MIS-C story in the pediatric group, that the attack is really on the vasculature more than the cardiac myocytes, although I think it's still reasonable to call those cases myocarditis because that is really the best description of them.
So Ivana joins us from Finland, and she says that the problem could also be with sampling, and that we need representative samples to reach any conclusion. And cardiovascular pathologists need to be involved from the moment of sampling, and then on.
Yeah, that's a great question, and that's a huge difference by institution or country. Is how much of the heart do we evaluate at autopsy? So in the United States, in a typical coroner's office, they may take 1 or 2 sections. At a hospital setting, they may take 3 or 4 or more. In Italy, among the cardiovascular pathologists, they take a minimum of 10. And so it's quite variable, which is true. So it's possible that we're missing subtle collections of inflammation. But going back to what Margaret Billingham had said, if you don't see it diffusely on the sections you look at, it's probably not going to be a cause of death. And so you're probably not missing a real myocarditis. You might miss collections of inflammatory cells, or it's not really clear. I had this case of an explanted heart with a person who had a very clear cause of heart failure, need for a new heart. And on one section out of the 8 that I took, there was this florid eosinophilic myocarditis in the septum, just an incredible amount of material. And I couldn't believe it because everything else was pristine. And I went back and took 10 more sections of that heart, and there was no inflammation anywhere other than this one section of the septum. And so what do you do with that information? Like, is this a myocarditis? Or is it not a myocarditis? He had a reason for heart failure that was, I think it was a genetic disorder. And so why would I want to label this as a myocarditis? And so the sampling can kind of bite you in either direction. It's hard to say. But yeah, in general, more is better. And we don't necessarily take enough, but it has to do with the cost of each additional piece that is taken and what's allowed to be done at various institutions.
Yes.
Ivana would actually like to know the mean number of sections in the cases studied. Do we know how many sections were taken?
No, I don't know that.
It's quite variable.
It is quite variable, and even I think one of the studies that described myocarditis in a couple of their samples were just biopsies, which was an impressive diagnosis to make on a biopsy. And they didn't say if they're like a true cut biopsy or like a wedge biopsy or how they acquired it. It's just called biopsy. And that would be very useful information. I know that the ACVP, SCVP paper in the European Heart Journal, they had tried to get many sections. Again, these are cardiovascular pathologists. This is what we love to do, is take these sections. So they were able to get more than is typical. And in fact, there were some arguments that they oversampled relative to other groups to find evidence of myocarditis.
A question from Harish. He would like to know the consent issues or policies if you decide to preserve the entire heart. And if this is permitted, do you hold the funeral services after the finalization of reports?
Well, that is going to be a question that varies from country to country, jurisdiction to jurisdiction. In the United States, we have consent forms for autopsy. We are an opt-in country. Some places are opt-out. Some places I know in Eastern Europe are opt-out, meaning a person can get an autopsy performed unless someone signs that they don't want it. But in the United States, a family member has to sign for an autopsy. At that point, depending on the language of that, materials can be kept for research or just performed and kept for a short period of time. Traditionally, in my institution, autopsy materials are only kept for 3 months and then discarded. We save a small amount of tissue from each case in like a forever bag should genetics become an issue years later or some reason to go back and evaluate something based on some new information, but that rarely gets reopened, those bags. When we have explanted hearts at my institution, we have been keeping those for a longer period of time that we can go back to, but it's so variable depending on the institution and the laws of either the state or county or whatever that jurisdiction is.
True. Dr.
I think that's
Sandhamani
it.
Madam has joined.
Good evening, madam.
Good evening,
Thank
ma'am.
you.
How are you?
Good evening. Thank
Yeah,
you.
yeah.
Thank you for inviting me and giving me the information, the link today evening only I saw that.
Yes,
Dr.
yes.
Halushka, it's a really enlightening talk that you have given, summarized it very well, and it gives us a lot of food for thought. I'd like to ask you one question, if I may. You said there seemed to be a predominance of involvement of the blood vessels in the myocardium. Do you think it's possible to do any further studies like electron microscopy or immunohistochemistry to identify the virus particles, whether they are within the myocardial cells themselves or involving the blood vessels directly more? Would that help us in understanding the pathogenesis of this infection?
Yes. Well, so thank you for your kind words, and that's also very important work that people are doing. So there are many different approaches to identifying the virus in cell types. One is electron microscopy. As you said, the challenge is interpreting electron microscopy. There is a paucity of expertise in electron microscopy of the heart. Just going to flat out say that there's very few people who really know that area well, and these viral particles look a lot like things that are natively seen in the heart. And so there's been a lot of misinterpretation by EM, and that so they may not be the best approach to look for this, just because a lot of people reported things that some of us have shaken our heads and said, I don't know. They could be pointing to a normal organelle part.
Yeah.
So that's
But
one
what about
concern.
immunohistochemistry? Would that help?
Yes, so there are many studies by immunohistochemistry of various proteins of the SARS-CoV virus that I have seen. I've seen them in cardiac myocytes. I have seen them in other areas. I have a colleague at Johns Hopkins, Charlie Lowenstein, who has been studying the vascular components of SARS-CoV-2 for a while, and he gave a talk at the USCAP meeting and said that he has no evidence that the virus can infect endothelial cells. They have no evidence showing the virus is in endothelial cells. And I have a second colleague at Johns Hopkins who has tried to infect endothelial cells ex vivo in a petri dish and also failed to infect endothelial cells. So at least from my institution, there's two different reports saying that endothelial cells are not infected, although they're quite involved because they're responding to this inflammatory condition that's going on. But yes, again, you could look by protein, by immunohistochemistry, as you said. RNA in site 2 hybridization, people are using both forward and reverse strands to show active viral replication in cells. And I have seen all sorts of reports in every direction.
So do you think can we understand whether there's a propensity for involvement of endothelial cells or smooth muscle cells or myocardial cells? Is there a difference?
So there's probably there is a difference. The challenge has been, I don't want to use the word biases, but the competing interests in where the virus is occurring. I have seen papers that suggest it's in the cardiac myocytes. I have seen papers suggesting it's in pericytes, the cells that surround the blood vessel. I have seen suggestions that it's in either native or infiltrating inflammatory cells that appear in the heart. The most unbiased data has come from single cell studies where they take cardiac tissue, break it apart and say, well, what are the cells that have the receptors for which the virus can even enter the cell type? And ACE2 being the dominant receptor. And that seems, from the earliest reports, was highest in the pericytes with very low levels in cardiac myocytes. So it was hard to understand how it could really show up in heart cells at a high level. But anything is possible. With 500 million people who've had this infection, at least likely that range, anything could occur when you've had that many different infections. This is what's common and what's not common. And it just doesn't seem that infiltration of the heart from this virus is very common. Everything can happen.
Very good. Thank you very much. Very interesting. I think more work in this direction will help to differentiate these ideas which are evolving now.
I would agree.
Yeah. Thank you.
Oh, I think, are there any more questions? Okay, I think we've run out of questions now. Thank you once again for accepting our invitation and for being here with us today. Before we end the meeting, perhaps you would like to, tell our audience about, the work that's being done by the SCVP, or, for those who are, just watching us right now, maybe they would like to find out a little more about the organization.
Oh, thank you so much for that opportunity. So again, thank you for inviting me. This was a pleasure for me to give this talk. And as you mentioned, I've just become the president of the Society for Cardiovascular Pathology. We have a webpage, scvp.net, that I would encourage anyone to come and visit. We have a lot of educational materials on our website. We have unknown cases, dissection tutorials. We will be putting out an electron microscopy tutorial very soon that we've been working on for a year to provide information on how to look at EM. As I mentioned, that is a real challenge. Our society is becoming more active throughout the year now. Our goal is SCVP 365 to have events throughout the year rather than just have them once a year at our meeting that we have in conjunction with the USCAP meeting. And so I would encourage anyone to come visit us and check out what we can offer, and to join us if you're interested in engaging with other cardiovascular pathologists. So thank you for that opportunity.
I think it's a really exciting time to be involved in cardiovascular pathology, particularly because, there's so much increased interaction between people across the world, particularly in the last year. And I think that's wonderful. We look forward to having, many more speakers from the United States on our webinar series. And thank you once again for joining us. This talk will be made available on our YouTube channel. We've been a little lax with our newsletter, but we hope to put it out, this month's newsletter out within the next 3 or 4 days. And we hope to be back on track for next month's newsletter as well. Thank you so much, everyone. And we'll see you again in 2 weeks. The next talk will be focused on medical students. And that will be actually part 2 of our lecture series, that's cardiovascular pathology for medical students. So it would be great if everyone could come back again for that. Thank you so much.
Thank you very much.
Thank you. Thank you.